Very good morning to you everybody joining us, and welcome to this Health Foundation webinar, which has proved to be extremely popular. I'm Jennifer Dixon and I'm really pleased to be your host today. So today we have a really big treat. We have an hour with Dr. Tim Ferris, who, as all of you know, is NHS E&I's first National Director of Transformation. He heads a directorate which draws together NHSX, improvement and innovation in a single team, which are assets I think we all know are absolutely crucial for the future. And he was also, before he started his executive position, he was a board member of NHS E&I for nearly 3 years. I think it was Tim before. Yeah. So Tim brings really interesting experience to the National Health Service, and not only is he a physician, but his career up until the NHS has been in the United States, most recently as Chief Executive of the Massachusetts General Physicians Organization, and before that leading population health management at Mass General in Boston, overseeing one of the largest ACOs, that's accountable care organizations, in the United States. He's done many other interesting things. Check out his bio. So he brings really deep and varied experience and, very importantly, fresh eyes to our National Health Service. And now he is centre stage in helping to move the NHS forwards in these very challenging times. He's also extremely nice. So very welcome, Tim. Really pleased to have you here to chew the cud on a few things for the future. But before we kick off with Tim, just a few housekeeping things. Today is, as all of you know, the second anniversary of the first lockdown. Some of you might want to observe a minute's silence at 12 midday to reflect on some of those who died in the pandemic, not least NHS and social care staff who we lost. Of course, please feel free to do that. We're going to power on through it, but as I say, please feel free to take a moment if that's what you would like to do. It's also, by the way, the Chancellor is doing his spring statement today, so hopefully we won't need a minute's reflection for that as well. Today's webinar is being recorded and the video is available on our website within 24 hours with subtitles added afterwards, so check those out. As I say, we have an hour for discussion today. We're going to finish just before 12:30 to allow Tim to go and get a sandwich before his next meeting. Now, this is a nice participatory webinar, so please ask some questions if you like. There's a Q&A box at the bottom there. I see some people already asked some questions, as some have done beforehand. So please look at those, add your questions, and I'll try and get to the most popular ones. You can upvote them as well, as you know. So thank you to everyone who's already submitted questions. And then the last thing, for anyone who would like to tweet, today's hashtag is hashtag NHS Transformation. So please tweet away. Right, so Tim, welcome again. And I thought what we might do is maybe kick off with a few words about you for starters. So I guess the obvious question is, why did you want to come to the NHS? And it must be a bit weird. So tell us what your impressions are so far. Thank you.
Jennifer, thanks. And it's a real pleasure and honor to be here with you today. And just reflecting on the fact that that I had a really wonderful interview with you quite a while back, and it's interesting to reflect at that time, trying to help out a set of hospitals in Eastern Massachusetts go from being essentially competitors vying for patients to being collaborators in the delivering optimal care for patients. And really, you know, at the very heart of your question is your question about why would I leave there and come here, is the opportunity to do that at an extraordinary scale, at the scale of an entire country, which through years of hard work has chosen to go in a new direction. And that new direction around ICSs, integrated care systems, and the using governance, organizing governance as if the patient mattered, so that everyone was on the same team taking care of their patients, is I think it's a profound moment for this country. It's also a profound moment because of the capacity challenges that the NHS faces. And these are capacity challenges throughout the spectrum of care. There are capacity challenges in acute care, in elective care, in outpatient care, in primary care, and very importantly, in social care. And so what I see the challenge and the opportunity in front of us is new organizational principles and really a burning platform for how to get it right, using this opportunity of change to really get it right. And then let me conclude by saying, to me, the most exciting aspect that really pulled me in here is the opportunity to really work across the whole spectrum of care. And what I'm talking about is the integration of social care with healthcare, because I think you know, Jennifer, in my background, my academic background and all the research that I did for years in health economics, I kept coming back to the driver that social determinants of health have on the utilization of the healthcare system and the powerful hinge between social care and the delivery of effective healthcare. And that hinge is, the US healthcare system is actually not well suited to advance the integration of that because of the way it's organized. And it is this new organizational principle and the opportunity to build on the governance changes to make it really operate, not just the anatomy, but the physiology of a delivery system.
Yeah. When people talk about integrated care, it almost reminds me like the Fukuyama end of history, that actually it's the only thing to do for the future. And certainly that's true across Western Europe, isn't it? And people talk about it because it's the right thing for patients, because who wouldn't want joined up collaborative care? But what you're saying is something more than that, isn't it? Is that it's the key to sustainability of the social model of the NHS, because only that way can you get the role changes of staff, sustainability of the workforce, and indeed the benefits of data and digital. Is that what you're trying to say? And indeed work on population health.
That's exactly right. And let me be clear, I am the scale of the opportunity is large. The challenge is also very large, because if anyone's listened to Matthew Taylor, talk about complex adaptive systems, talk about the NHS and social care in this country is a very complex adaptive system. And you don't just go in and tweak something and expect to fix it. No, it will move. All the different pieces need to be working well together. And that is a really difficult challenge. It involves understanding the key parts, how those key parts function, and then what is the change process for those key parts in order to get you to that better functioning state. But as you said, Jennifer, I think every observer of the delivery of healthcare understands that even as you maximize the benefit within a particular service delivery, if you have not thought about how it connects across the continuum of care, then you are expanding costs and complexity to an unsustainable way. So bringing back to the word you use, it is about sustainability and providing a platform, the context for the delivery of care and healthcare that will be sustainable and will achieve all the things we all share in terms of our aspirations.
So you talked about some of the moving parts and to have synergy between them. You've obviously got some key assets in your new directorate. Would you like to tell us a little bit about the directorate and what's in it and how it works? Yeah.
Yeah, so let's get specific. Enough platitudes. So the big opportunities. Well, I will actually go general for one more second and just say two huge macro trends in human understanding are occurring. One is the biologic sciences and the other is digital and data, right? So those two macro trends have transformed all aspects of human life on this planet. And healthcare is literally at the intersection of those two things. It's about communication and information, and it's about human biology. And so the opportunity in healthcare to maximize the advances in digital and data and in biology and biotechnology are vast, right? But getting your arms around how you do that is really challenging. And so, yes, so the Transformation Directorate includes everything from, the working with my partner Simon Bolton in NHSD, and the sort of, if you'll pardon the expression, working at the bottom of the tech stack, all the technology that needs to be in place to enable the work at the top of the tech stack, which is the analytics, the population health, the use of data to drive information that allows us to understand where we can improve, all the way to the very top, which is research and development. How do we use our data assets and all of our assets within the NHS to advance the science that's biology and biotech that is going to, again, lead us to greater sustainability and better outcomes. And I know everyone overuses this, but it's true. I mean, the vaccine, from everything from the research involved in the vaccines, which is really new research actually, to their deployment across the population, was an extraordinary effort that involved all of the elements, right, of that continuum that I just described on the tech stack. So everything from the basic tech to the data and informatics, the digitization, the analytics around vaccine deployment, supply chain utilization, all the way to the recovery trial and rapid cycle use of information and rowing together across the entire country, which is what happened in the recovery trial, in order to provide insights that saved lives literally the day after the results of the recovery trial were known. And so we've seen it now. That's the exciting thing, right, Jennifer, is that we've actually seen it work. We've had a flavor of what is possible. And then the big question is, can we do that not in this narrow thing, big as it is, called COVID and the pandemic, but actually, can we do that across all of healthcare? And so that is the Transformation Directorate's charge, daunting, and I will say, not one of the challenges that my team faces they're not new. They've been known about for a long time, and the opportunities have been known. But there is a new sense of can-do and confidence that we can make more progress more quickly against these really big challenges.
That's great, thank you. So you've got, just to be practical for a second, you've got the digital and data bits in there, which is big enough, and you've got an improvement bit, and you've got an innovation bit, and you've got other bits as well, important, cross-cutting, like Inequalities Bola and her work. Are those the main aspects that you want to point? Yeah.
Well, I think I like to think about it, yes, but I like to think about it in terms of priorities, in terms of topics and methods. And the topics you just named, right? So we've got the pandemic. Hasn't gone away. We're still working on it. We've got the recovery and the recovery of services, the elective backlog, and we've got health outcomes, which have been slipping in this country. We need to do a better job on health outcomes, and we've got the inequalities, which I will say is, as I travel around the NHS, the ambition to address inequalities is the most powerful animating force that I find throughout the NHS. It is just wonderful to see what people are doing locally against all those challenges that face anyone who's trying to innovate or create change. And that is a unifying, animating force, is the determination to make a big difference in health inequality. So those are the topics. The methods are, we have to digitize, we have to connect those digital platforms, and we have to use those connections to transform services. So to use the NHSX branding slogan, we have to digitize, connect, and transform. There are lots of things we need to do in all three of those categories. There's some basic infrastructure in the digitize. This country doesn't yet, not every social care trust or acute care trust actually have an EPR. We are not fully digitized, so we've got to get that base. There's work to do on just bringing the base up, because we can't make those connections until we actually make the information digital. And then on the connect side, the big opportunity here is both on the care delivery side to enable, just as Emily Lawson was able to do with the delivery of the vaccine program, to really be cited on exactly how we're doing and where we're not doing as well as we think we could or should, to provide support, not through performance management, but through improvement. And that's, Jennifer, where I love the fact that we're bringing innovation together and data together with improvement, because it's a approach to management which is not a top-down thou shalt approach, but using data to identify where there are where we've underinvested in the basic infrastructure supports, where we need more investment to make that improvement possible. And then there's the transform bit on top of all that, which is, I view transformation as both inside out and outside in. So inside out is innovation that occurs in our HSNs, in our academic centers associated with the delivery organizations. And I see such extraordinary work. I was just at Greater Manchester HSN meeting, excuse me, on Monday, and they are doing brilliant stuff on population health and health inequalities and virtual wards. And then I was at an HSN meeting in Southwest London, and they've got some amazing AI-driven patient instruction materials that I immediately thought, after seeing them, wow, everyone in this country should be benefiting from these materials. They're fantastic. Instead of getting a letter from your doctor, you get a link to a video, and the video is an animation that is verbal and visual, that takes your test results from your complete blood count or your electrolytes and explains each one of them to you, and it's culturally specific. Like, it was stunning in its use of technology. And I thought, that's the kind of innovation that is truly transformational. But Jennifer, we've had challenges with spread. Like, how do you take that innovation and spread it across the country? There is certainly an appetite for it, but there are barriers. And so I'm thinking that the team that I'm very proud to lead has the capacity to enable that adoption and spread. But it really comes through a change model that is, I like to summarize as the role of the center is to convene and to make joint decisions, so that it's not the center making the decisions, but we're sitting around a table making a joint decision. But once a decision is made, and you do have to make a decision, then the center's job is to support locally led initiatives. And that model seems to be, it seems to work well, I think, in the culture of the NHS. And it certainly works well in a complex adaptive system where really every piece of it has to be on board with your priorities for change, or else you're not going to make much progress.
Yeah, thank you. So while we're on the subject of innovation, I mean, there's one issue, isn't there, which is demand signaling by the NHS. I mean, you can have a lot of innovation, but actually it's not tackling some of the key things that you've set out, like recovery, like indeed workforce or sustainability or productivity or quality. So there's a bit of work there, and I know that there's been a lot of work to try to improve demand signaling, as you say, by the HSNs and the Accelerated Access Collaborative. Then there are funding programs to stimulate innovation on some big challenges. And there's a question there about, there's the AI, which NHSX has put together, the AI in Health and Care Awards, 140 million. And there's no doubt other funding pipes coming from OLS or, the life science sort of agenda. But then there is something which is like, it's horizon scanning and spotting, identifying not just useful innovations, but useful innovations that could be game-changing for service design that can tackle some of the big things. So can you say something a bit more about the horizon scanning sort of system as far as use? I mean, there are, HSN and the Health Tech Connect and so on, but how efficacious is that, do you think, to spot?
Yeah. So I'm so glad you brought that up, Jennifer, because in my prior answer, I was focusing on the internal improvement, and what you're talking about is the world out there is doing amazing things.
Yeah.
And how do we bring those amazing things to the benefit of the citizens of this country in a much more sort of rapid cycle way? Yeah. And I, the NHS has had a reputation of being, from commercial and industry side, of being difficult to work with, in part because how you intersect, how you get adoption of a particular game-changing technology was often at the level of a CCG, right? And so going around to hundreds of CCGs in this country is not exactly a method for rapid adoption, right? And so I do hope and expect, well, first of all, that problem is well recognized by everyone, internal to government, Whitehall, NHS, all the arm's length bodies. And so, as you said, there are groups getting together specifically to address that. And I will say that my colleague Matt Whitty and the Innovation Research and Life Sciences Group, OLS, Sam Roberts at NICE, UKHSA, and June Rain, and all of the colleagues across those groups are now getting together regularly and asking the question that you just asked, Jennifer: how can we do this better? That's a start, right? Just the fact that they are regularly getting together, acknowledging that this has been a challenge. And I will say, Ara Darcy, who chairs the AAC Collaborative, this has been his cause célèbre, because he sees all that innovation outside of the NHS, and working himself inside the NHS wants to bridge that in a much more rapid cycle way. So I think so it's really encouraging to see agreement that this is a challenge we need to take on. We are doing much more demand signaling. Demand signaling requires that you actually know what your priorities are, right? And the NHS has for very good reasons, been a little bit reticent or reluctant to state a small list of priorities, because you get this right, Jennifer. It's challenging because anyone who's not on that list immediately says, "Oh, what about my thing?" And so that's been a challenge for the NHS. So so demand signaling and signposting where we're going. I think all of that is getting better. We are working on that. I've had lots of meeting with both in the biotech and pharmaceutical leaders about working with the NHS. But I'll tell you the thing that they get most excited about, and I think is our big opportunity, is they see the ability to test at scale in a very rapid way their innovations, and with the promise, such as the Grail arrangement, of saying, you know, we're going to test it. If it doesn't work, thank you very much.
That's good. Just say that there are innovations that have been spotted early on. So they've got NICE approval, they've been tested in a little way, or MHRA approval. And then there's the valley of death, isn't there? There is this issue of not being able to get much beyond 1 or 2 sites. So I guess the question there is, what is the mechanism that now needs to happen to enable this mass and rapid testing? Just as a preface here, you know, we at the Health Foundation and others do evaluations of things like virtual wards, like telehealth and telecare. These evaluations take forever. They're large multi-center trials, and they often don't have any D attached to them. So which could also come from your outfit, which is an improvement engine to help support people locally. So I just don't know what your thoughts are there about the infrastructure we've got for rapid testing and the rapid cycle that you talk about.
Jennifer, it's a great question. It does come down to me as the core enabler here is data and real-time data, because evaluations shouldn't be this thing that is separate and requires separate infrastructure to be applied to a particular situation. We should have the facility to measure what we need to measure continuously, so that when we're making changes, we simply use that existing infrastructure to in a quasi-experimental design way. So for example, the NHS is beautifully set up for things like group randomized trials, and using those opportunities to test and then deploy. But even in the deployment, you are monitoring the benefit that is deriving from those changes. Because, and this is an important point, I'll go back to something I said at the very beginning about the hard work of integration. So the hard work of integration really is that it is possible to, for example, put in place an anticipatory care program for your most underserved, or a virtual ward program. The need is so great, it's quite possible to implement that program and actually not address your systems issues. So it's possible to implement a virtual ward program and not reduce the bed capacity, not free up bed capacity in your hospitals. Mm. The way to avoid that problem is through measurement. And measurement at that scale requires the digital infrastructure to be in place. So you see how all these things are connected? The digital and data is actually critical for that transformation. And it needs to be at scale. It doesn't work if it's as patchy as it currently is in the NHS.
And that's helpful, thank you. And if we are wanting to test things at scale, how do you see the new network of 42 odd ICSs being part of the picture? How might they learn rapidly from one another? Perhaps learning from what we found out in the pandemic. Actually, there was quite rapid, WhatsApp groups understanding how to treat patients. what benefit is there of these 42 ICSs, and how would they interact with you? In the past, we've had collaboratives. In a sense, we've had a push factor to identify and really push in national priorities into the system through, for example, through the Modernisation Agency. That's slightly at odds, isn't it, with the need to have local agency? So how do you see this balance in your
Well, it's a great question. And in fact, Jennifer, on April 6th, it is the very first meeting of the CEOs and chairs of those 42 ICSs. It is a very exciting moment for the NHS to have all of those people in a virtual room. And this will be, and Amanda is chairing that meeting, and this is about co-producing how we're going to work together. And that's really exciting, Jennifer. You think about the power of the power of the potential for that group to both define how it's going to work together and against the key priorities. And the key priorities here, one of the big challenges here is there are that relatively short list of national priorities. How do you make sure, because locally they're going to have priorities that will be specific to their local situation.
Yeah.
And how we arrive at a balance, you use that word, Jennifer, I think very appropriately, a balance between giving enough headspace for leaders to address their local problems, but also make sure we're rowing together against the problems that everyone faces. That, as you know, Jennifer, that is a challenge, that is a tension that is inherent, and you don't solve it, you manage it. And you manage it by acknowledging it and saying, we're going to have to do some of that local stuff, and we need to give you space to do that. At the same time, they need to turn around and say, there are some things that we share that we need to work together to address. And I'm really looking forward to that meeting as the kickoff of a new path for the NHS working together, even as it allows for the important creativity and local variation.
Yeah, indeed. That sounds very exciting, that's a new mechanism. But I mean, all the stuff that we've done and others have done looking at how innovations are spread or indeed adapted locally, is that there's a lot of work in adaptation, isn't there? It's not just a pill, it's not just a bit of kit, it's all the humans around that and the role changes and all of that, which rather lazily gets called resistance. It's not really resistance, is it? It's just appropriate adaptation locally often, and the kind of mechanisms that help unlock that that speed up include very basic things, don't they? Like time and space, like staff who are allowed to take time away from some of the absolutely critical must-dos to be creative. A forgiving management style, messenger review is working on that, isn't it? Data, as you say, and also some kind of system of whether it's quality management or quality improvement, whatever you want to call it, some kind of system that is used to using rapid cycle methodology. You've got an improvement bit in your empire, if I can call that. How is that going to work to support what could be quite significant adaptation, even if you spread things like virtual wards, which are around probably half of the country, but not the other half?
Yeah.
How is the improvement system going to work? Are you going to have national collaboratives, do you think, or are you going to work through the ICSs in some other way? Sorry, this is probably on your to-do list, but I'm just interested how you figured this so far.
Yeah, Jennifer, it is on my to-do list. And in fact, had this discussion with the entire senior executive group, including the regional directors, just yesterday. Like, we had a prolonged discussion of exactly in fact, you articulated it almost exactly the way it was articulated. And here, let me just say, this is not going to be a very satisfying answer, except to say that everyone present acknowledged that that's probably one of the most critical things. Answering that question in a productive way is probably one of the most important things that we're going to need to do. We didn't have an answer, yeah. But I took away quite a bit of solace from the notion that everyone, it was completely recognized that that is a critical piece of this. And I want to specifically call out Navina and HEE and the role of the workforce here, because this is about investing in our workforce, because you described it perfectly, Jennifer, and this is to me the nub of it, which is, how do you give people who are doing their jobs the space to also improve their job? Yeah. And when we are constantly chasing the next really big priority, where actually, and if it feels like the whole thing is going to fall down unless we dedicate 100% of our efforts to it, which is not an uncommon feeling, I will just say, in the NHS. How do we take that system and provide people with the space to work on that improvement so that you can get ahead of it, right? So that it's not all feeling like it's imminent and urgent. And that, given the sort of staffing challenges within the NHS, that is a really, really significant challenge. But I just want to end that comment with it on an optimistic note, and that is, as I go around, as I do every Friday, and watch people working, watch people innovating, and learn from them, it is so true, Jennifer, how much positive energy is born from participation in creating that future. Like, there's the intrinsically motivated people who work in the NHS, which is the vast majority of people who work in the NHS. It just feeds their soul to have the opportunity to make things better. And so it is on us to figure out the mechanism by which we are going to both structure and process the mechanism to enable that to happen.
Yes, I always remember the work also of, you probably know Larry Casalino, do you, Tim?
Yes,
back in the primary care days in the US. And one of the things he said really helped in terms of innovation spread was something that helped to make the day of the clinicians better, or it helped to make my day better.
Yes.
As well as improve care for patients, of course, because with the staff under the cosh, that's going to be quite a significant thing with sustainability, which is where we started off, isn't it?
Can I pick up on one thing there, Jennifer, which is the way I have become adapted to talk about that is friction. So as a physician, and this may have been the core of how I started down this path, because as a young clinician in the early 90s, I was both honored and thrilled to be giving care, but I quickly realized that the quality of the care that I was able to deliver depended critically on the resources I had at my disposal and my ability to make use of those resources. And I saw so much friction in like there are these resources, but getting those resources and the patients connected was really challenging. And I think that's how I started down this whole journey of trying to, make the system better. I do see a lot of friction in the delivery of healthcare in this country. And that means there are lots of opportunities to reduce the friction. And if we focus a good bit of our energy in digital data and transformation on reducing friction. So as you said, Jennifer, making a few minutes of every day a little better, where that will have legs, that will carry us forward. So reducing friction needs to be one of our, for the people delivering care, needs to be one of our highest priorities.
Yes, and reducing friction also for patients, in particular,
yes.
patients who are use care a lot, and that's where inequalities are particularly pertinent, isn't it? There've been quite a lot of questions about inequalities. You know, how addressing inequality will be a priority in service transformation. Asked Kirit Mistry, who's chair and founder of Race on the Agenda. So that is something, isn't it, that's central. And actually, Wade Gary put the patients at the centre of transformation, didn't she, in her review?
Yeah, that's
now,
right.
I'm doing very badly because there are lots. Your talk has stimulated 70 questions, and so thank you, patient audience. I will come to some questions now. So one is a really interesting question from an anonymous one, which is about the role of, clearly the NHS is one big asset in the country, the biggest industry, but how might private industry who are developing some of these innovations help? You know, what do you, where is their lift other than developing innovations and investing in them?
Yeah.
Where do you see them helping?
Well, I think they help in multiple ways. One is just having multiple models coexisting is just good for the ecosystem, because you learn. Others make different choices and you can learn from those choices. I don't know that we systematically learn as much as we could from the fact that there is an independent sector, because there are certainly opportunities to work more closely together. And I say that very carefully in the sense of collaboration and learning from each other. And so that's one of the key opportunities that we could do better at. The other is the adoption of innovations is not just a problem for us. It's a problem for everyone. And so the specific challenges that we face, we can learn from others and create environments. I think we would do well to look out of the NHS more often than we do. We can be insular, and we have a lot of work to do. So it's perfectly reasonable. But I think we can. There are opportunities to use the commercial sector, the independent sector, the biotech industry to help. Because what is amazing to me is the shared core beliefs in the need to make healthcare better, health outcomes better. That is an animating force that binds us all together, even if we have differences in funding and allocation and the finance model.
Yeah, thank you. There are some questions again about what, if we want to build a transformation engine that you're describing, what kind of, are there different, this is where my engineering knowledge, are there different pistons in the American engine? What other ingredients might there be that you can see that we might be lacking? And we haven't really talked about incentives and so on and so forth, but
yeah,
what can grease the wheels, to mix metaphors, of change?
Yeah, so so money does grease adoption, and I'll just say my personal view is that while the U.S. adoption of technology is dramatically more rapid than it is in this country, and that's not a controversial statement, but I would say it may be there's too much grease in the U.S. and the adoption of technology is maybe undisciplined. The key to me is finding the sweet spot, right? And so I do think that it is very clear from the American healthcare experience when it comes to the adoption of technology and change that funding and incentives matter. And I'll just tell you, the US pretty much went from 0 to 100% adoption of EPRs because they put a boatload of money into, they gave the money to hospitals and said, if you spend, we will pay for you to adopt EPRs. And literally within a 3-year period, the hospitals in the United States were all digitized. Now, the magnitude of the money spent dwarfs what has been spent in this country on digitizing, and so there's a balance point there, right?
Yeah, was that public money, the high tech and high tech?
It was the High Tech Act, exactly.
That's David Blumenthal, isn't it, from the Commonwealth Fund, who was.
That's correct. Yeah, and one of the most successful government programs ever. I mean, if you think about what they set out to do and what they accomplished, they did it, and they did it quickly. But it was very well funded.
And do you see, there was a question about interoperability, how to, do you see that that's a major issue within, paradoxically, one system, the NHS? And I suppose the interoperability wouldn't be between, you know, what X or Y hospital is using, but also across the primary care, you know, can EMIS talk to Epic and stuff like, sorry, this is all getting a bit technical, but to what extent is that an issue that you have to work on as part of your infrastructure building?
It is Jennifer, it's a critical issue. In fact, last night and much of yesterday and much of the past couple of weeks has been spent on exactly that question. Because Jennifer, how will we, I'm sure you know the Secretary of State's announcements about his ambitions, which I just say I'm very proud to be a part of. I think they're the right ambitions. But if everyone in the country is going to be able to see their records on their phone anytime they want, it will require us solving some of these interoperability problems that you just described. And those problems are mostly not technical, interestingly enough, because the international standards, fire and other HL7 and fire standards are there to make that happen. But we have some work to do, both on the technical side, also on the tech adoption side, about what tech we're adopting and what the rules of adoption are, but also on the regulatory side, to bring it all together to enable that moment when you can see your records when you're in an emergency department because you were hiking in the Pennines, but your records are all in Cornwall. You and the doctor and nurse taking care of you should all be able to see the critical information. That is a absolutely doable exercise.
Yeah.
But we have some challenges to overcome to get there. I'll just say I'm absolutely committed to making that happen.
Very good to hear. Just a niche question on the US experience. In terms of the speed of adoption, too much grease. Do they have much lighter regulation then? And is that something we better focus on if we're going to try and unlock faster change? Do you know?
It's a little, yeah. There are, so yes and no. So and I'm not the best person to answer this question, but my impression is that the scope of regulation, particularly around technology, is more limited in the U.S. So it's not that the regulatory process is any tougher or looser. It's that the scope is a little different, and so more things fall out of the scope of the regulatory process.
Oh,
it's a little more permissive in terms of technology than this country is.
Oh, that's really interesting. And hopefully that's on the sites of MRHA and Sam at NICE. Yes. I think amazingly time is flying, and I did say I'd give you time to have a bite of your
it's okay.
Sandwich, whatever it is. But maybe if we can finish with one question, because it's come up quite a lot. And that is how to put the patient at the heart of the transformation agenda. And in particular, given our improving but still probably not adequate tagging of ethnicity in some of our data, which must be better in the US, how do we move on this? Because if we can't see inequalities, if we are not really listening to patients, then because the data isn't also tagged very well, how do we really move forward on that agenda?
Well, I don't know. I think there are just on this U.S. comparison, it very much depends on the state that you're in, because that the degree to which that issue has been addressed is a state-based issue, and so there are some states that are actually are quite forward-looking in that, and others that aren't. I guess what I would say is, yes, Jennifer, that is really important, but there's a lot we can do even with what we've got. And again, I'll point to the vaccine data and just say, just knowing an address can get you a long way toward addressing inequalities. And you have to be careful in how you use the data, of course, and it has to be secure and thoughtful. But it's certainly true that even while we work on improving the data we have, the data that we have access to, we can still do better with what we've got now.
Yeah, good. Thank you so much. Well, I think unfortunately time has flown, and Tim, we've had so much of your time. I really do have a rich selection of questions here, 83 of them, which we'll certainly have a look at. And Tim, can I send them to you as well? Because I think your team will be interested to see these wonderful questions everyone has asked. Thank you, all of those who have done that. But we really ought to leave it there. Looks as though we should probably have a part 2 at some point, Tim, because we've just scratched the surface on, and maybe when you're further into your program and you know, that you can come back and let us know how it's going, and we can ask other questions. But thank you very much. I think we're all behind you, Tim, I think is the answer. And also it strikes me, you know, this is the Transformation Directorate is a great sort of hope, actually, isn't it? It's one can spend all the time polish the problems, but actually what you're doing is putting together a great set of assets, which we've never really put together in such a way before. So very good luck with your program, and let us know how we can help you. I'm sure everyone on the call would say that too. So for now, thank you to Tim for all these insightful answers, and to thank you all for watching and for all your great questions. If you like this webinar, you'll like the other ones. So we have one a month, so sign up to our webinars. Here's the link on the chat and on the screen. We also have a podcast a month as well. So if you like webinars, you probably like that one as well. And if you'd like to, it would help us a lot. Please just email us with some feedback. How did it go, and how could we improve? In the spirit of rapid cycle improvement, I think that's what we'd like to do. So your feedback would be very helpful. Thank you very, very much. Don't forget the 1 minute silence at 12:30, not for the Chancellor, but for all the contributions to the COVID pandemic by NHS staff, and also to all those who suffered as a result of the appalling pandemic we've been through. So don't forget that. But meantime, many thanks. See you again. Stay well, and have a good rest of your day. Thanks so much. Bye-bye.